Hello and welcome to our video on the surgical treatment for management of congenital pseudarthrosis of the clavicle. I am Peter Chalmers. I'm at the University of Utah. These are our disclosures. They're not relevant to this particular video. So this procedure is performed with the patient in the supine position. You can see we've marked out and exposed the clavicle and the pseudarthrosis. You can see the motion through the pseudarthrosis. We're going to be using titanium anatomically contoured plates, and first thing we're going to do is make sure we have enough exposure and choose our plate, and then what we're going to want to do is make sure that we get the pseudarthrosis circumferentially exposed. So we need exposure all the way around the back of the pseudarthrosis, and the reason why is because we're going to want to excise the pseudarthrosis. So I'm going to use a reciprocating saw here to excise the entirety of it. And the reason for this is we need all that tissue to be gone. That tissue is non-healing. And you'll see when we remove it, and again, you need this circumferential exposure here because the plexus and the vessel are behind it. There's actually what looks to be almost articular cartilage in the middle. It's very smooth. That tissue is non-healing and has to be completely excised, I think, for this to heal. So once we've done that, we're going to drill the ends to try and get some fresh healing surfaces here. So this is about cannulating the endosteal surface in that location. This is our iliac crest autograft, and we've measured it here. And what we're going to do here is make some marks to try and figure out how we're going to get it to fit. And we're going to cut it into a T, and the apex of the T is going to go anterior, and then the leg of the T is going to go interposed into that gap that's created by the excision of the pseudarthrosis. So you can see here we're marking out the T, and we're going to try and preserve that top cortical surface and then instead remove some of this surface beneath, because that top cortical surface is going to be some of our best, highest quality bone. So this almost makes this into kind of like a little bone plate that's going to sit on the top of the clavicle. So we'll work very carefully to remove the edges of those T at kind of here 90-degree angles. Once those are removed, again, we're going to have this T of bone with the leg of the T planned to go into the middle of the pseudarthrosis, and then the arms of the T fitting over the top. So we're going to see here, we can manipulate the bone, we can fit that T into the gap, and that's going to look like it's going to fit just quite nicely. And then we're going to be compressing with the plate to try and get that to heal, and then we're also going to be compressing over the surfaces. So here I am burring the anterior surface of the clavicle, and this is to create a larger surface area so that both the arms of the T and the leg of the T are healing. This way we get maximum surface area for healing on both sides. We're going to definitely want to overbend our plate a little bit to make sure we apply some compression on the far side, and we'll make sure that fits nicely. We'll get our plate fitted in, and then we'll get our graft fitted once we've got the plate kind of clamped in a good location. So once the plate is clamped on both sides, then we're going to have that opportunity to slide the graft into the middle. So once that's all fit, so now we get our graft in, and again, the cortical surface of the T is going to go anterior, the plate is going to go superior. We're going to fix on one side, and then we're going to compress through the other side through the plate. So we're going to want to clamp the graft in place as we do this to make sure it doesn't move. So you can see here we're eccentrically drilling to be able to compress through the plate. And then as we tighten down this screw, it's going to compress both sides of the graft. So you can see here, once we've done that, the graft is actually quite stable. And then I'm going to do a second one. So we're going to doubly compress. So once we get this one down, we're going to want to loosen that other screw. And then we'll drill and fill the rest of the plate to try and get 3 bicortical screws on both sides. You can see here now the graft is actually quite stable, and there's really no opportunity for it to move. Once that's done, we're going to actually put screws through the graft into the clavicle. And the reason for that is because we're going to want to compress those other 2 surfaces. So we've got compression both at the endosteal surface of the bone and then also at the periosteal surface of the bone. So this is basically a lag screw, and this is what makes that into almost like a bone plate. All right, thank you.